Okay, so good evening, and welcome to my grand rounds entitled Pediatric Cochlear Implants, Hearing Preservation, and the Canadian Perspective. I have nothing to disclose. So the objectives for today's grand rounds are twofold. The first is to gain a general understanding of the Canadian healthcare system and how cochlear implants fit within this context. And the second is to acquire further knowledge of cochlear implants in the pediatric population, in particular to review the candidacy criteria and to understand the shift in practice towards hearing preservation. The presentation outline is as follows. First, we'll briefly talk about the history of cochlear implants, and then we'll discuss the cochlear implants within the Canadian healthcare system. Next, we'll talk a bit about the expanded candidacy criteria and some limitation to cochlear implants, and we'll end with a discussion on hearing preservation. So before I begin, I'd like to take a few moments to thank those who contributed to my presentation, in particular to Dr. Kay Chang, who has provided a fair amount of feedback, as well as to Alan Chang, and to a number of individuals from the Cochlear Implant Program in London, Ontario, and that's where I did my residency. In particular, Dr. Stuart Irgawal, who did his fellowship here, Kim Zimmerman, who's a cochlear implant audiologist, and Jamie Lewis, who is an audiologist also affiliated with the program. So starting with the history of cochlear implants. In 1790, Alessandro Volta, he's the Italian physicist who invented the battery. He was the first to electrically stimulate the auditory system. And he did this by placing a metal rod, one in each ear, and connecting it with a 50-volt circuit. Once this circuit was completed, he reports a boom within the head, followed by a noise like thick boiling soup. Now, he then went on to say that this experiment actually was quite unpleasant and uncomfortable and deterred him for further pursuing this area of research. So nothing much happened until the 1900s. And in 1930, Weaver and Bray found that electrical response recorded from the vicinity of the auditory nerve of a cat was similar to the frequency and amplitude to the sounds to which the ear had been exposed. In 1936, a few years later, two more researchers found that hearing could persist following surgical removal of the tympanic membrane and the ossicles, and it was therefore hypothesized that the cochlea was the site of stimulation. And then in 1957, Giorno and Eries found that they could generate sensation of hearing by direct electrical stimulation of the auditory nerve. And this is actually very interesting. This patient that you see here was a 57-year-old woman, and she had bilateral large cholesteatomas. And she underwent temporal bone resections bilaterally 1 week apart, and was left with profound sensorineural hearing loss, as well as transection of her facial nerves bilaterally. So Eries was asked to take this patient to the operating room and to reanimate her facial nerve, which reportedly he did. But intraoperatively, they found what they thought was the distal, or I guess the residual stump of the cochlear nerve, and decided to put a electrode in the vicinity of this stump, and then the coil tucked underneath the temporalis muscle. Now, post-operatively, and the actual technicalities I don't quite understand, but when they were able to generate sensation, she was able to perceive sensation of sound. However, there was no speech recognition or frequency recognition. So in 1961, William House developed a single-channel cochlear implant and conducted the first nationwide clinical trial. However, due to the lack of biocompatibility, there was a lot of device failures. In 1972, again, William House developed the speech processors. And with the development of the speech processor, as well as improvements in biocompatibility of the actual device, they were able to implant, as estimated, over 1,000 devices over the next 8 years. Around the same time, Graham Clark from Australia announced the first multi-channel cochlear implant, and this was marketed and branded as the Cochlear Nucleus Freedom. Rod Saunders, who you can see in the bottom corner, was its first recipient. Now, there was a national press release stated that he was actually activated 1 week after he received his implant, and they were saying that when he was presented with the national anthem, he stood at attention with the light. So it was quite a big thing for Australia, and essentially for cochlear implants. In 1985, the FDA granted the first approval of cochlear implants, and this was in the adult population. In 1990, the FDA granted approval for cochlear implants in children, so not that long ago. And then today, there are 3 main companies, Med-El Corporation, Advanced Bionics, and Cochlear Corporation that do cochlear implants. So really in the past decade, there has been basically skyrocketed number of publications in the world of cochlear implants, and it is far exceeding already. We can see here in 2004 the dotted line, which is the hearing aid research. So when I was preparing these grand rounds, I was asked to talk a little bit about the role or how cochlear implants fit within the Canadian healthcare system. And in order to do that, or for you to understand, I thought we'd talk a little bit about the Canadian healthcare system itself. So this here is our Parliament. It's on Parliament Hill in Ottawa. Lovely building. Anyways, in Canada, hospitals are not-for-profit, and they are funded, the majority, by the provincial government. The provincial government allocates hospitals a sum of money, and then it is up to the hospitals to distribute the money according to the hospital's needs and services. The exception to this is government-funded provincial programs, at which point a fixed amount of money would be given to the hospitals for a particular purpose. And this is the case for cochlear implants. When a Canadian is born or you newly immigrate to Canada, you are assigned a health card or a health card number. And once you have that, you are insured. And it is estimated that 95% of Canada's population is covered. Physicians bill the government directly on a fee-for-service basis. Private insurance does exist in Canada, but it is only for non-Medicare covered services. So for the most part, this means outpatient pharmaceuticals, but also means like orthodontic work, non-hospital-based dentist work, and optometrists, for example. So in 1984, Canada devised a healthcare act, and it's based on 5 primary principles or pillars. The first is public administration, which we've already alluded on, that hospitals are run on a public basis, non-for-profit, and the authorities of, or the administration is accountable to the provincial government. For comprehensiveness, basically this means is all medically necessary services are offered and fully covered by the government. For universality, all Canadians are covered, irregardless of their socioeconomic background, irregardless of comorbidities, irregardless of lifestyle such as smoking and alcohol and whatnot. The fourth is accessibility. It's thought that all Canadians should have access or have the right, not the privilege, but the right to health care, irregardless of their geographic location and independent of, or in the absence of any financial barriers. So, for example, if you lived in a rural community or northern Canada, the government would then cover you to have you come to tertiary care hospitals if necessary. And the fifth is portability. Basically, this just means that if you're insured if you live in Ontario and you move to BC, you will still be, your insurance is portable across provinces. So, what about cochlear implants in Canada? Well, right now there are 10 centers across Canada that perform cochlear implants. In Ontario, there's London Health Sciences, which we'll talk a bit about more in a minute, and they perform 50 implants a year. Toronto, with 190, in Ottawa is 50. Now these numbers include both adults and children, and I unfortunately do not have access to the data that further teased the adult pediatric numbers out. So speaking a little bit more about London, Ontario, the hospital there is part of the London Health Science Centre, and this is our building. It is affiliated with the Schulich School of Medicine and Dentistry and the University of Western Ontario. And the otologist neurotologists there are Dr. Lauren Carnes and again Dr. Sue Aguilar. Also found in this building is not only one, but three coffee shops for Tim Hortons coffee. And after moving here, I definitely appreciate that it's very much a Canadian entity.
Yeah. Can I ask a question just about the healthcare system?
Yeah.
So I've got a friend who's an otolaryngologist in Canada, and he makes a lot more money than I do here. And he's, I guess they're all kind of university bit, where he's in a university. Yeah. Well, I thought they're not supposed to make as much money, right?
No, you have it backwards.
So national healthcare, we get more money.
So the way it works is it's a good question. The hospitals are not for profit, but the physicians bill the government independent of the hospital budget. So that's why I think every province has a separate fee schedule, and we'll talk a bit about, again, the numbers for cochlear implants, so you'll be able to see for Ontario anyways. But yeah, the Ontario Medical Association, they set out a fee schedule, for example, in Ontario, and physicians bill the cost of services, which is fixed to the government. Yeah.
You also have a rationing of the specialist, so he may have a monopoly where he's at. There's no competition like there is in the United States.
That may be.
Doesn't the government tell how many otolaryngologists, how many otologists, how many laryngologists?
Yeah.
It's much
Exactly.
more of a pyramid there.
Yeah.
A true primary care pyramid than it is here.
Right. So that's why.
So if you're at the top of the pyramid, that's a good thing.
You need to be paid more. Ask for more money.
Yeah, right. Rob will love that.
So cochlear implants are funded by a government program, and we talked a bit about that already. For example, in London, the government last year agreed to fund 25 cochlear implant devices a year at the unit's list price. So what that means is that these are examples of last year's quotes for list price for the cochlear implants. So I am not privy to information as to which numbers they actually used when they did these calculations. But we'll round it up to say $33,000 per device times 25. So the government will allot, for example, just over $800,000 a year to the hospitals, and that money has to be spent on cochlear implant devices. So once the hospital secures the funding for the devices, the hospital then enters contract negotiation with the companies. And what happens is the companies, the Mid-L, Advanced Bionics, and Cochlear, will submit a proposal to the hospital, and they will indicate how much they're willing to sell the cochlear implant to the hospital per unit price. And often what happens is the companies will list their price or selling price about 40 to 60% of the list price that I showed you on the previous slide. So once these proposals are submitted, they're evaluated by the committee comprised of hospital administration, surgeons, nurses, audiologists, and it's scored out of 100. 40% of this is attributed to the company that gives the lowest quote, and the other 60% will be based on the technical advances, their customer service, and those kind of things. The winning contract secures 80% of the volume for that year, and leaving 20% of the residual budget to be spent on any other of the other two companies. So this is an example. So what we've just talked about, that's for device only. When it comes to physician services, like I mentioned, you bill directly, for example, for OHIP, if you live in London, Ontario. And you would bill the government for a surgical consult $135. And then that money is directly coming back to the physician. The physician doesn't have to share that with the hospital or give a percentage to anybody else. That's back to them. And the surgical OR fee, so roughly $700 for a unilateral cochlear implant. The CT scans or imaging, OR costs, audiology appointment, free admission was estimated about $5,000, and that cost is assumed by the hospital. So for example, I guess in terms of an overall estimate in Canada, a unilateral cochlear implant would probably cost close to $40,000, and that's money paid by the government. So, yeah, go ahead.
Can you go back 2 slides just to make one quick point?
Yeah.
So this thing about the contract exists
Yeah.
here too. Now,
Okay.
we don't get 40 to 60% off the list price, but maybe 75% off.
Wow.
But the deal is you have to guarantee that you will use it. 80% of your patients will have that implant. And the hospital loves that because they get a cheaper price then. Parents and patients don't like that because you have to steer them to one brand. And they're not all the same and they oftentimes they want to pay. So what we did here is we had to negotiate with the hospital to allow us to not have a deal like this. And it's a going rate based on whatever volume per year we have. They'll give us a discount. And so I think the hospital doesn't make quite as much money off of it here because we want patients to be able to choose their device. But most hospitals in the US have the same thing, and they do the 80%.
So the process. So eligible candidates are discussed at the cochlear implant committee meeting. And because in Canada it's based on more of it's not scarcity of resources, but I would say limited resources, patients are ranked according to priority. And as a result, we have a hospital ethicist to make sure that this ranking system is as ethical as possible. Once you're on the list, the waiting begins. The current wait time, once you've been on the cochlear implant list, is about 6 months to a year. And that actually is much improved with the new government funding. Before, in the recent past, actually, when I first started residency, it was up to 3 to 5 years wait list. So, and just a bit of a comparison between the wait in Canada, again, is based on the limited resources, whereas in the US, when patients wait, it's mostly waiting for approval, insurance approval. So there is a Canadian cochlear implant group. They meet on an annual basis and they devise some recommendations. Current recommendations for adults is they receive unilateral cochlear implants. And there's currently a study going on. It's a multi-center study, and they're looking at the benefits of bilateral cochlear implants in adults versus the impact on the wait list, again, given our limited resources. In children, however, bilateral cochlear implants is the standard, and it is highly preferred and encouraged to proceed with simultaneous cochlear implantation. So what about bilateral and simultaneous cochlear implants? Well, a lot of this data comes out of the Sick Kids with Dr. Papson and Dr. Gordon, who I believe was recently here. But basically, it's safe and cost effective. There's no significant increase in surgical time or hospital stay. There's bilateral auditory pathways can have the opportunity to develop in tandem, and it optimizes by oral hearing. Rehabilitation for both ears is concurrent, and there is better receptive and expressive language skills compared to unilateral cochlear implant users. So moving into a bit more didactic material, what about cochlear implant candidacy? Well, candidates are really assessed by a multidisciplinary team, which consists of an audiologist, a social worker, psychologists, and physicians. They need to be medically fit, have absent active middle ear disease. They need to be up to date with their vaccinations and have imaging, or be an anatomical candidate. So pediatric audiometric candidacy criteria is based on age. For children aged 12 months to 24 months, it's bilateral profound hearing loss. For children aged 25 months to 18, it is bilateral severe to profound hearing loss with a minimal hearing aid benefit. Both of these groups need to show that that they lack auditory skills, minimal benefit with hearing aids, they have no medical contraindications, and that they're enrolled in an education program emphasizing on auditory development. The criteria, however, is expanding to include both younger children and to children with severe to profound high-frequency loss with preservation of low-frequency hearing. There is a group in Italy, Coletti et al., who are looking at implanting children younger than 6 months. They have a system in place that allows them to identify children who meet the Audiometric criteria. And within the study, they had 45 patients, and they were placed into 4 groups. So they were implanting children 2 months to 6 months in the first group, and then you can see the breakdown of the other groups. All of these children were implanted with a cochlear nucleus, and they looked at their performance outcomes. So with regards to speech perception, they found that the participants in the 2 to 6 month old group scored better on the CAP testing than all the other groups, and that there was no significant difference between age-matched normal hearing groups. So the 0 to 6 is the lightest gray, and the normal hearing is in the white column. With this CAP test here, and I'm not, to be honest, completely familiar with the CAP testing, but this was the CAP 2 testing, which included the CAP 8 and the CAP 9. And in the CAP 8, it was a hearing and noise scenario as well. And the CAP 9, they said there was a telephone conversation with an unfamiliar voice in an unpredictable context. And just to note, the follow-up time here, that's 48 months post-implantation. With word comprehension, they found, this is a bit of a busy slide, but just kind of focus on the 42 to 47 months at the end, that the participants in the 2 to 6 month group scores were not significantly different than those implanted in the 7 to 12 month group. But they did identify that there, again, was no difference between the 2 to 6 month group and the normal hearing age group. So this makes me think that perhaps there was no difference with the 7 to 12 month group, perhaps because of a low sample number, for example. Again, so Patson et al. And Coletti et al., they wanted to see if this was actually safe to go ahead, and they looked at their complications. So both of these groups found that there was no additional surgical complication rates, no anesthesia complication rates, that post-operative issues or skin tissue breakdowns that were more significant than the other age groups. So moving on to children with severe to profound high-frequency hearing loss with preservation of their low-frequency hearing. So this is, I think the audiometric criteria is shifting or changing to include pediatric patients also with this type of hearing pattern. This is an audiogram from the Med-Al website, and in some centers they may put the cutoff at the 1,000 hertz for severe hearing, so perhaps the full diagram may be shifted a little bit to the left. But the general terms, I think, can be shown here, and that it looks quite a bit different than the audiogram you may expect with a severe to profound hearing loss bilaterally. So why is this important? Why are we researching this area? Well, we know that for patients with bilateral severe to profound sensory neural hearing loss who have been implanted with cochlear implants, they are capable of providing very high levels of speech understanding and quiet backgrounds. However, there's 2 shortcomings. One is hearing and noise, and the other one is pitch and music recognition. So there's a group here, Henry et al., and they focused on, they measured frequency resolution. And that essentially is the ability to respond to a single frequency in an acoustic stimulus with when other frequencies are present. And they looked at 3 groups, the normal hearing, hearing impaired, and cochlear implants. And they found that the normal hearing participants had the best results, but that the hearing impaired groups performed better than the cochlear implant groups. And this is an adult population, I have to say. But nonetheless, I think think this research, along with a lot of other research, has indicated that minimal amounts of residual low frequency hearing is beneficial for hearing and noise. So the second shortcoming is pitch and music perception. So a group of researchers found that normal hearing individuals were able to discriminate piano notes one semitone apart, and this was significantly different from cochlear implant users who were able to discriminate notes about half an octave to 2 octaves apart. So along the same lines, Siosa and al., they looked at pitch cues, and they looked at the Cantonese language. And they found that few Cantonese speaking cochlear implant users scored above the chance levels in word identification. And that's because they use pitch cues for word identification. And then the last group was intonation cues with Pang et al., and they found that on average, cochlear implant users distinguish half as many question statement pairs as compared to normal hearing subjects. So there's been a lot of research and literature on this, but the bottom line is that preserving low frequency hearing during cochlear implantation can improve hearing and noise, as well as music and pitch recognition. So these are a few goals for preserving hearing, and most of these are, well, all of them actually have to do with the surgical technique. So you preserve the auricular chain, you attempt to decrease the acoustic trauma by decreasing the drilling on the cochlea. The electrode insertion, the goal is to be within the scala tympani, close to the spiral ganglion or the medialis, and to minimize the intracochlear damage, so whether that be a round window insertion or a soft cochleostomy. There's other techniques like minimizing bone dust, minimizing the suctioning of perilymph, and injection of either steroids or the helon. The next question is can hearing be preserved in children using a standard length electrode array with full length insertion? There's a lot of talk about this in the adult literature, but there actually is not that much in the pediatric literature. And the question is yes. So Brown et al., they looked at 31 children with severe to profound hearing loss. And in order for their inclusion criteria, one low frequency had to be better than 75 dB. They performed a soft surgery protocol with using a standard electrode. And they were able to preserve or achieve complete preservation in 45% of the patients. And that was defined as a postoperative threshold shift less than 10 dB and partial presentation up to 90% of the patients. So once we know that hearing can be preserved, is there any impact on performance? And the answer is also yes. So a group, Carlson et al., they looked at 118 participants. And again, they at 250 hertz, their hearing was 70 dB or better. They adopted, again, the soft cochleostomy or round window using a standard electrode, and they were able to preserve hearing in 55% of the people. And then they looked at their performance. So in particular, you can see here the CNC, they're both speech perceptions, but that's like the cochlear nucleus consonant test, and the other one is the AZ Bio, which is sentence testing. The post-cochlear implant scores are better than the pre-implant scores, as expected. But within the post-cochlear implant scores, participants in the black column with hearing preservation performed significantly better than those with non-preserved hearing. So we know that hearing preservation then can be achieved. We know that it is associated with better performance. And the question is there anything else that we can do should we achieve the preservation of low frequency hearing? Well, what can be considered is electric acoustic stimulation of the low acoustic stimulation of the low frequencies and electric stimulation of the high frequencies. And again, this is fairly common in the adult literature, but there isn't that much published in the pediatric domain. So a group of researchers implanted 25 children with partial deafness using a round window technique, and they did the full insertion with the flex electrode or a partial insertion with the 30mm electrode. And they reported that they were able to preserve hearing in 88% of their population group. In terms of performance testing, the post-cochlear implant scores exceeded the pre-implant scores, and the EAS function, which in this case was the duet, exceeded the cochlear alone or the electric stimulation alone in both quiet and noise. And they found that insertion depth had no difference. So when it comes to implanting children with bilateral, high-frequency, severe or profound sensory hearing loss and low-frequency preserved hearing, full insertion is preferred because children have a greater rate of progressive hearing loss than adults. And also the low-frequency electrodes can be deactivated and to allow for acoustic stimulation of this. They can be reactivated, or I guess initially activated, once hearing loss progresses to include low frequencies, and this helps to avoid the need for reimplantation. So in summary, in Canada, cochlear implants are dependent on government-funded programs. The Candidacy criteria is expanding, both in terms of age as well as with individuals who have preserved low frequency hearing. That hearing preservation is attainable and associated with better receptive and expressive language skills within the pediatric population. And that cochlear implants is an ever-growing domain of research and advancement. And I think it'll be really quite exciting to see how things evolve over the next few years. Thank you for listening.
On the Coletti study with the under 6-month-olds, did they do anything with electrode changes related to head growing size?
No, that's a good question. They didn't mention any of that.
It wasn't even mentioned, but there were no complications though, right?
There was no complications, no.
Did they use the nucleus 24 or 26? Do you know?
The cochlear nucleus. The Coletti study?
Yeah,
It was a nucleus.
it was a 24.
Oh, the length of electrode?
No. The number of electrodes.
Oh, I don't.
I think that's
I don't
is
know.
that
Probably
what?
They used
22.
the
22, nucleus
cochlear
22.
nucleus,
They had
yeah.
48-month follow-up, so it was probably done a while ago.
Right before the. What's the current state of the art now? How many?
I mean, it's not the question of how many. Like the 3 brands have different numbers of channels, and they actually all provide equivalent performance when you test them.
Okay.
In fact, the studies show that having any more than 6 active channels doesn't improve performance at all.
Huh.
So all the extra channels are kind of helpful for backups in case some start to
Yeah.
fail,
Right.
which wires do tend to break over time.
Interesting.
It's kind of scary when you think about how rudimentary these are,
Yeah.
but yet how much good performance you get out of it.
Yeah.
I think that was a wonderful talk.
Excellent.
You know, the earliest you can implant, obviously, the better. I mean, brains are learning as soon as, right?
Yeah.
If you could implant in the womb, it'd be the best. The question is the technology providing something that the child can benefit from at those ages? And it probably is. And is the risk worth the benefit?
What percent of dead ears do we have in our program here, in children, pediatric?
Dead ears? You
Yeah.
mean like deaf?
In other words, failures, total failures, and loss of total hearing with the implant.
So the question is, when we implant, what is our percent of preserving residual hearing?
Exactly.
Yeah. And so that's a tough thing in children because they do have a higher rate of progression. So oftentimes, by the time the audiologists actually try to check their hearing, they may have already progressed to the point where they wouldn't have had any anyways. And I would have to say, we're not very careful about having a standard protocol for doing pre-op testing, post-op testing, and
Mhm.
how we do it. As kids are growing, we're doing different tests at different ways. I mean, the best would be an ABR,
Yes.
and to repeat that at different time points
Yeah.
for everybody, and we don't do that. It'd be neat to be able to do that.
How long are these implants expected to last? Like, what are they telling the parents when they're implanting and they're 3-month-old, like when they're going to need a replacement or?
Yeah, that's a good question. I'm not sure for the time itself, but I do know that they do have a talk with the parents and say there is a chance of, especially if they're young children, of having device failure in years to come. And I don't know actually if there's literature. I think because it's pretty new still.
There's
we're not,
literature.
Okay, yeah, I'm not familiar.
It's
with
about 10% of the kids that we
it.
implant.
In how many years?
Well, it depends. I mean, the follow-ups are different, but roughly 5 to 10 years. It's about a 10% breakage rate.
But I mean,
Or
they've only been
reimplantation.
around since the 80s, so we only have, 30 years of data from the oldest devices, and these kids, should be living into their 60s or 70s. So I guess I'm just curious, sort of what's sort of ahead for the child that gets implanted in infancy.
So one thing that I have read about is that the other benefit of doing these hearing preservation techniques will also, some research think, minimize the intracochlear damage, which then in turn, if you, 5, 10, or whenever the device breaks down, you need to remove it and reimplant it, they'd have less intracochlear damage. So the reimplantation can technically be easier to do. But other than that, I don't know what they're quoting.
10 years.
Do you have
Every
that,
10 years you
those
might need to get a
discussions?
I quote them 10. Oh yeah, I quote them about 10 years. You might as well plan on getting it changed out.
Okay.
Because if it hasn't broken by then, the technology will have improved so much you'll want.
You'll want it.
Many of the older ones, they don't even service them anymore. So if the external part breaks, you can't buy those components,
Oh.
and so you may reimplant just because of device obsolescence. Now,
And do you have to pull the
maybe-
electrode out too, or is it just the?
Yeah, no, you pull out everything. And actually, the new one slides in really easy, and they work as well or better than what they had. So it's surprisingly not a big deal. I mean, it's kind of like changing a part of a car.
Interesting, I heard just recently I was at the Las Vegas hearing preservation conference that Cochlear was running a couple weeks ago, and someone made the point that, these new ones do slide in a lot easier because they're smaller. But now everyone's using these small little slim ones. What happens if you have to change those out? If you take the small slim one out and then you have to put a new one in, it may actually make the reimplantation 10 years down the line a lot harder.
It may.
But everyone's using the slim ones now.
With the old ones, they're bigger. You get the scar tissue sock that forms around it. You pull it out, and there's a big, path to send to the new one. Yeah, you're right with these new ones. Hopefully, there's no scarring with these.
Bill House was an amazing person. He gave me a few implants many, many years ago for free. The single channel device that he had invented, the all hear device. And his goal was to be able to have the third world that cannot afford such expensive implants and be able to use them. So I took several of these and implanted several children in Iran in the early 1991, 92. And I just heard recently from one of my patients that it was still working till last week.
Wow.
The
great.
processor even was working.
Wow.
20 years later,
My
this little
God.
single channel processor. And that little 9-year-old that I implanted in 1992 speaks very, it was post-lingually deaf and sharp, but was able to use this implant all these years. I just got an email saying, do you have a processor now, because it failed.
So what are you gonna
And this was a pro bono charity case that I did back then, and now I don't know where I'm going to be able to find a processor for that.
do?
Also, about a year ago, I saw an article in Business Week about a company in China that makes an implant that I think only has like 6 channels, but sells it for like $800.
Wow.
And $800.
You send that around.
Yeah, I mean,
remember
this
reading
is
that.
the way to go. I mean, these implants here are doable in this country, but in many parts of the world, $30,000 is totally unreachable. People make maybe $5 a day, you know, $10 a day. It's just impossible to come up and tell them, oh, this is not. You know, the private practice here, you know, I'm sure Stanford's bill is the same way. If you look at the bill for a cochlear implant, they ever recently looked. One of my patients brought a bill from one of the local hospitals that I've implanted, and the bill was for the implant, the hospital's bill, not my bill, $225,000.
Gouge.
Wow.
That's a gouge.
And the
That's for
hospital,
the implant.
the hospital was really upset because they only got paid $50,000 on that bill. And they were upset at me saying that this is really a costly operation because, you know, we only got 1/4 of our bill. I said, well, gee, you can bill $1 million and get paid. Why did you bill $225,000? The patient brought me the bill. I mean, I saw it, it's 8 pages and at the
That's
bottom.
amazing. That is
So-
an amazing bill.
These are really unheard of. I'm sure Stanford's bill
We're
is also.
expensive, but not at that level.
I bet you it's 90,000 is the.
Oh, yeah, it's around that range, yeah.
Because the insurance companies.
But
don't
insurance
pay.
doesn't pay it.
But to answer your question, I know personally, my patient from 1992 that was using a single channel all hear implant till now, till 2013.
That's really good.
Amazing. I did about 8 implants those years, in that year, and 8 or 9. All of them were working till the 2000s. So Bill House was into something good. That device was a good device. And it was a short electrode, so it was automatically preserved hearing in most patients. It was a single channel short electrode, 20 millimeters. So automatically it was atraumatic.
Thank you very much.